the arrival of the results from THOR for erdafitinib was very timely because this is the era where the landscape of bladder cancer is changing or has changed drastically since the approval of enfortumab vedotin. So I think THOR gave us some more perspective on the sequencing aspect, though not hasn't really clarified it. But for example, when erdafitinib, which is the pan FGFR inhibitor, that was first FDA approved in an accelerated form in 2019, it was based on the results of the BLC-2001 study that had about 99 patients. And at that time, it showed overall response rate of 40%. And also showed the median PFS of 5.5 months with survival of 13.8 months. The treatment itself had some significant side effects, which did include hyperphosphatemia, stomatitis, GI side effects. So when this was done, THOR was being planned as a more definitive study. So it's a phase 3 study. The THOR cohort 1 had 266 patients where patients had those patients who had received prior lines of therapy, including immunotherapy. So majority of these patients had received chemotherapy as well as immunotherapy, and they were randomized to get erdafitinib versus chemotherapy, which included docetaxel or vinflunine. And these patients must have the FGFR alterations. The median overall survival for the group of erdafitinib was 12.1 months, and the overall response rate was also very similar to what we found in the initial study, the BLC-2001. So the overall response rate was around 46% versus 12%. So the cohort 1 kind of solidified that use of erdafitinib in bladder cancer patients or advanced bladder cancer patients, rather in this case, who have FGFR altered tumors benefit from erdafitinib as the second line and beyond therapy. The cohort 2 was different. So it was comparing patients who had received prior platinum therapy and randomizing them to erdafitinib versus immunotherapy, the checkpoint inhibitor. And that study showed that the overall survival was comparable. So in January of 2024, FDA has approved erdafitinib for advanced urothelial cancer patients who have received previous immunotherapy and whose tumors have alteration of FGFR3. So I think in this notion, since the first line therapy has already kind of moved over to enfortumab vedotin and pembrolizumab, and in some cases, the gemcitabine, cisplatin, and nivolumab, the second line for these patients could definitely be erdafitinib. The molecular testing has become part and parcel of our management plan for, all advanced urothelial cancer patients. So in my clinic, I would always do molecular testing for advanced urothelial cancer patients from the time I see them, because I want to know what's driving the growth of their cancer. I want to kind of identify these specific mutations early on, so then we can have some options open. And as THOR has pointed out, I think, in the THOR study, I think majority had the testing done on their tumors through the RT-PCR and then also the next generation sequencing. So these things do take time, depends 1 week, 2 weeks. So then, and you can also include the time that is taken to process the pathologist to actually send these tumors. So give and take probably 2 to 3 weeks to actually get the answer. So I wouldn't say we should wait to get these answers. I think these patients, when come in, hopefully would be started on their first line therapy, but it would give us time to know if the patient has the FGFR alterations. Now, there's specific FGFR alterations, especially the FGFR3, that that the tumors, if they have it, the patients would benefit from the erdafitinib, which would include your R24-8C, the S24-9C, G37-0C. So the point is, like, we want to know early on. We also want to kind of know their PD-L1 status, which is looking at at this point, maybe that is irrelevant, but I think that's also interesting point to know, since all patients are going to get immunotherapy. And I think it's also important to kind of know some of the other drivers, that if any of the other, any opportunities that come in future to enroll them on studies that are targeting these specific mutations, then we can give that option to the patients. And as we are, I will tell you that in my clinic, I want to kind of give you an example. We have a few patients who have been treated. So the presence of these mutations is not in all urothelial. I would say in about 15 to 20% of patients would have, or would tumors would harbor these mutations that would be susceptible to the erdafitinib treatment. So we have a couple of patients who actually have benefited. So we've tried them chemotherapy when the initial BLC 2001 results had come in. It was in second line and beyond. So we tried chemotherapy, and then of course immunotherapy was moving around. So the patient had gotten the immunotherapy as well, and my patient then ended up being on erdafitinib. And we were just looking into, I think this patient is going 3+ years on low dose erdafitinib. And this is a patient who has metastatic disease to his lungs, having really good quality of life. And he couldn't tolerate the higher dose, but even the lower dose of erdafitinib has been very beneficial for him, which has given us the opportunity to control his cancer, as well as maintain the side effects with some conservative management. So I think that is the implication, or the clinical implication, you will see in your clinic if you do these tests early, to identify which patients of yours are ideal for these treatments. As a physician who treats a number of urothelial cancer patients, we were very excited when the oral therapy arrived, and erdafitinib was the first oral therapy and still is the first one that's approved. But it is a pan FGFR inhibitor, right? So it inhibits FGFR1 to 4. And we believe that while for the urothelial cancer, the FGFR3 is the main mutation, or the driver mutation for the growth, by inhibiting FGFR1 to 2 could cause some side effects. And these treatments, in whichever trials you see, about 45-46% of these patients are going to experience side effects. And some of them do affect quality of life. For example, the high phosphate in some patients, the stomatitis, the mucositis, or the diarrhea, or the ocular toxicity, or the nail toxicity. So these newer generation of FGFR inhibitors, like the LOXO-435 or the TYRA-300, and you were pronouncing it correctly. And I mean, these are drugs that are supposed to have selective FGFR3 activity. So we could spare the FGFR1 too. So those patients, perhaps would have less of the toxicity and could remain on the higher dose. Because as I just told you, a lot of patients need dose reduction as well while being on these therapies. So our hope is that this could change change the efficacy and the tolerance data, and further pave a way for inhibiting the FGFR positive tumors. The LOXO-435 is being tested with and without pembrolizumab, so more results to come. So we know some of the other FGFR inhibitors, may have not shown the similar efficacy as the erdafitinib, but we believe that the newer inhibitors would definitely show better efficacy and hopefully better tolerance. I think that would be the key for our patients. This is certainly an era where a lot of newer therapies are being developed for urothelial cancer. So while the field has just changed with enfortumab vedotin combination therapy with pembro, I think a lot of studies will now come into, because you have to realize that the EV-302 study, or rather EV-302 Keynote 839 study, the overall survival was 31.5 months. So anything that goes into the first line therapy has to kind of jump that bar, as opposed to the non-muscle invasive bladder cancer, or or even muscle invasive bladder cancer. A lot of studies are being done, and the most exciting, I think, a drug that's coming up is the THOR-210. So THOR-210 is a newer modality of intravesical delivery of continuous erdafitinib in the bladder. So you probably may have seen the THOR-200 results that contain it's like a pretzel form that the urologist would insert into the bladder, and then the drug would continuously disperse in the bladder and cause anti-tumor effect. So the THOR-210 has erdafitinib, and it is being tested currently into these high-risk BCG unresponsive or refractory non-muscle invasive bladder cancer. In fact, we saw some of the prelim results last year that they showed for two cohorts of it. One cohort were high-risk non-muscle invasive bladder cancer who had previous exposure to BCG, and 82% of these subjects who were enrolled had control of the disease, or what we call as the recurrence-free survival, although the median recurrence-free survival was not reached. And there was another cohort of 27 patients where they enrolled high-risk, intermediate high-risk non-muscle invasive bladder cancer, where they had visible tumor. So the previous one had TURBT done and then the treatment was done, whereas this one, they still had to have some visible tumor. And among 15 evaluable patients, I think 87% had really complete remission. So more data needs to come out of this, but this is an exciting strategy for patients who have this localized disease. We can give these treatments are more tolerable. Some of the side effects are dysuria or hematuria, but grade 1 to 2. So that, again, they don't get so much of a systemic side effects, so as to speak, like nail toxicity and stuff. But certainly more results need to come, and this might be a strategy that could be adopted to localized urothelial cancer tumors with FGFR alteration, especially FGFR3.